am Stephanie Green, and I'm here to present today on the Desert Regional Healthcare Alliance's discussion for the creation of COPD pulmonary rehab. The objective of our discussion will be that interprofessional members of the multidisciplinary team are able to identify the disease process, identify appropriate candidates for care, need for service, standards of treatment, funding sources, and financial sustainability of a pulmonary rehabilitation program. So, an introduction to our COPD population. This is a progressive life-limiting disease that generally affects persons over 40 who have a history of asthma or tobacco use, have a history of exposure to lung irritants such as secondhand smoke, air pollution, industrial dust, chemical fumes. Very rarely is it diagnosed before 40, and when it is diagnosed before 40, it's likely the result of a genetic mutation from an alpha-1 antitrypsin deficiency, but this is very, very rare. Generally, it is some sort of exposure-related disease. It affects approximately 3 million people who are newly diagnosed annually, and about 30 million people are treated annually in the United States, and it is deemed the third leading cause of death in the United States as of this year. Our typical patient is a non-Hispanic, divorced white female aged 65 to 74 with limited education and low employability and income, who has a history of tobacco use disorder. Some of the goals based on our care for this target population are going to be disease prevention through community education, decrease diagnosis of tobacco use disorder in our community, decrease hospitalization of those already afflicted with the disease, decrease emergency department utilization of those afflicted with the disease, improve patient-reported quality of life and disability scale scores, and decrease mortality associated with COPD. In order to obtain these goals, we will use specific interventions. In order to decrease the risk of disease, we would offer smoking cessation programs, including pharmaceutical therapy, community education, behavioral modification therapy to our community. We'll also develop partnerships with national, state, and local agencies to promote lung health, such as the EPA for air quality in the community, and the American Lung Association for air quality within the home. We will utilize GOLD and ATS-ERS guidelines in order to develop our programs. We will offer peer education to primary care providers in the community in order to improve the quality of care and subsequently patient outcomes of those being treated. And we'll improve workplace personal protective respiratory use for those with occupational risk of exposure to inhaled irritants. And in order to be in compliance with WHO guidelines, we will offer effective and efficient care coordination across the healthcare spectrum, which will also improve our outcomes. A brief pathophysiology of COPD. COPD, or chronic obstructive pulmonary disease, is an obstruction of the airways that occurs in both chronic bronchitis and emphysema, making COPD more of a spectrum of disorders rather than a singular disease. There are pathologic changes that occur within the lungs as a result of exposure to external stimuli, such as smoke, pollution, dust, and fumes, and resulting in poor gas exchange. Normally, when we are exposed to such stimuli, we do have some sort of inflammation. However, in COPD, the response is exaggerated and prolonged, and this is the result of activated leukocytes, cysteine proteinases, and plasminogen activators. Normally, these things are released to manage such inflammation, but the release is ineffective in persons with COPD, and that results in lung tissue damage. Additionally, these persons are subject to oxidative stress, which is generally caused by the noxious stimuli that we earlier discussed, and this stress can lead to cellular destruction in the exposed tissue. Regardless if the disease is chronic bronchitis or emphysema, we will be treating and managing it in a similar fashion. So the typical symptoms associated with COPD are cough with or without mucus, fatigue, shortness of breath, especially on exertion, chest tightness, frequent respiratory infections, shortness of breath, and wheezing. All of the symptoms are the result of narrowed airways, which results in poor gas exchange and ineffective secretion clearance. Most patients with the disease will seek treatment late in the disease, which really puts us up against the wall in order to better manage their care. So that's where the community education comes into play, letting the primary care providers know when to get a pulmonary function test and spirometry and when not to. 9 out of 10 times they'd be better off erring on the side of caution, just because the testing is fairly simple and is not highly expensive. Many of the patients who have early and mild COPD ignore their symptoms simply because they seem like they're going to be transient and suspect that maybe they're just the result of a cold or other acute illness. However, with retroactive questioning, we find that they wind up having a multi-year history of the disease. So things that we want to look for on assessment are hyperinflation or barrel chesting, wheezing upon exhalation, crackles upon inhalation, decreased breath sounds, hyperresonance to percussion, prolonged expiration, accessory muscle use, pursed lips, cyanosis, edema, and unexplained weight loss. Specifically, we want to look for paradoxical indrawing of the lower intercostal spaces, which is the positive Hoover sign. And in advanced diseases, we want to be aware of elevated jugular venous pulse and significant peripheral edema. Typical labs and diagnostic data are changes in their pulmonary function test, changes in their pulse oximetry, changes on CT, X-ray, or other imaging, and changes in their ABG. Since the cardinal symptom of COPD is shortness of breath, the empirical diagnosis focuses on spirometry. If the ratio of forced expiratory volume is 1 second to forced vital capacity, and that's less than 70%, then we can make the diagnosis. However, in mild disease, it may actually be higher than 70%, which makes it a little bit more complicated to diagnose. Changes in pulse oximetry may not be noticeable at first because of compensation. Use of those accessory muscles may allow them to have normal pulse oximetry, so the PFT really is the standard. Also, we can look at the CT or chest X-ray to show morphologic changes, but again, that's going to be more obvious later in the disease process. For someone who's presenting with any sort of signs of hypercapnia, an ABG is recommended just to make sure that we are capturing any changes in their respiratory metabolic balance. So some of the holistic therapeutics for COPD that we're going to offer are going to include breathing exercises such as pursed lip breathing, breath stacking, huff breathing, coordinated breathing, huff cough. We're also going to look out for some physical therapy to help improve activity tolerance. Additionally, since persons affected by COPD have unintentional weight loss and may be at risk for infection, we do want to elicit nutritional therapy, as they will need to have a diet higher in protein in order to compensate for poor intake. Nursing is going to be a key factor in the development of the multidisciplinary program because care coordination is key in the success of the person suffering with COPD. So making sure that care coordination across the healthcare spectrum, including DME, home health, physical therapy, oxygen supplies, is going to be very, very important. So making sure that we have the appropriate nurses in the roles to do appropriate care coordination and follow-up to make sure that that loop is closed will be integral to the success of our program. Additionally, persons who are suffering with COPD are at risk for a lot of psychosocial and spiritual crises. So we want to make sure that we elicit spiritual and psychosocial support in order to give them holistic treatment. We want to make sure that they do not have anticipatory grief or if they do have anticipatory grief, we are treating it effectively since this is a life-limiting disease. Additionally, they're at risk for the spiritual crises because they're going to be asking questions like, why me? What did I do to deserve this? We want to make sure that we are addressing them as a whole person and not just as a set of lungs, as has historically been done, and the reason that we are pursuing this type of robust care model. So in closing, we want to provide comprehensive care that treats the whole patient. We're not just treating the lungs, we are not just treating the inflammation, we are treating the whole person. We're treating their family, we are treating their community. We want to make sure that this is a comprehensive program that is financially sustainable In order to complete the financial sustainability, we are going to be pairing with those outside agencies at local, state, and federal levels. Additionally, if we move to a value-based purchasing model, having this type of care on board is going to improve our outcomes and also improve our reimbursement, which will improve our bottom line. We need to be thinking about a pay for performance versus a fee for service model, as most insurances are now seriously discussing, if not already implementing, such type of reimbursement models. If we want to survive the future, we need to think for the future. Also, we want to think about our outcomes. Beyond seeing the financial sustainability of the outcomes, we want to see our community thrive and decrease human risk. Human risk being modifiable risk factors. If we can decrease smoking, we can decrease this disease. We would like to see changes in the law, changes in cigarette purchasing, changes in tobacco sales in our community. And the only way to do that is through advocacy, which comes through community education and, again, pairing with those federal, state, and local agencies. I hope that this has left you with much to think about, and I hope to see in the future that we are able to bring our multidisciplinary clinic to life and better improve the quality of life for those that we serve. Thank you for your time. I hope you have a wonderful day.